Welcome. I'm Millie Solomon. I'm the president of the Hastings Center. And for the benefit of the newcomers, I'm going to spend just a few minutes saying a little bit about the Hastings Center for those of you who are new to us. We were founded in 1969, so that means that we've been independent and freestanding for just about 45 years. The Hastings Center has been credited with starting the field of bioethics because it didn't really exist as a word or as a field or have any institutional shape when it was founded in 1969. Our mission is to illuminate tough questions about what the right thing is to do in regard to health and healthcare and life sciences research. We lived, as you all know, in an era of enormous technological prowess. And all of the new scientific knowledge and technologies that are emerging are bringing benefits, but they also need to be thought about very carefully so that they don't bring harms along with those benefits. We're able to splice together DNA from different species and create new forms of life. As you've probably read in the New York Times over the last couple of days, we are able to create human beings from 3 different sources of DNA rather than 2. And the FDA is considering the merits of that as we speak. And all of us in our own personal lives have been touched by the fact that we now have technologies like ventilators and dialysis machines that can sustain biological functioning without necessarily bringing benefits. So all of these technological advances really ought to be thought about carefully, illuminated, as was the word I used before. And we are a place that's been committed to doing that since 1969. But it's not just the evaluation of technologies. It's also a big focus for us, and a continuing through line at the Hastings Center has been other things that are not dependent on advances in technology, like what's fair with regard to how our healthcare system should be designed, and what are the best ways that we can support patients' rights and enhance families' voices and try to cultivate a culture of medicine and healthcare that's about shared decision making and respect. And how can we, develop physicians and other healthcare professionals who are true to some of the aspirational ideals they had in the first place for going into healthcare? How can we help them sustain their empathy and their compassion and deliver really care that's basically altruistic and caring? And that is what brings me to the subject of tonight's presentation. Dr. Jordan Cohen is, fair to say, one of the country's preeminent medical educators. He's used most of his professional career, has focused on how to ensure humanism in medicine and how to help physicians especially, but he's also been engaging with developing interdisciplinary and team-based forms of healthcare as well. But the driving thread throughout his career has been how to build physicians who are not only technically expert, but also compassionate and true to, able to relate and stay true to their humanistic values. He's Professor Emeritus at George Washington University Medical School and President Emeritus of the Association of American Medical Colleges. For those of you who don't know, let me say a word about the AAMC. It's an incredibly influential and progressive membership association of all the medical schools in the United States and Canada, 450 teaching hospitals, and 90 medical and specialty societies. And Dr. Cohen led as president the AAMC for many years. So he has helped to shape how we do medical education, but also science policy and healthcare policy in a very, very fundamental way. So, Jordy, we are so happy that you have come up here on the train from Washington to spend the evening with us. So let me pass it.
Thank you, Millie. Well, thank you, Millie. I'm really delighted to be here. I've been a fan of the Hastings Center for as long as I was in a Hastings. Well, as a matter of fact, Now that I think about it, 1959 was the year before I graduated from medical school. I figured they had to have an ethics center to get ready for me when I entered medicine, right? Is that the whole idea? So anyway, the Hastings Center has been extremely important, extremely influential, and continues to be, I think, a major source of expertise and knowledge and direction for the profession, for the country, really. So I'm delighted to welcome Billy as the new president and to have a chance to speak to you all. Well, I picked as my topic tonight, healthcare reform, will your doctor still care for you? That's the question I want to raise. So first, let's talk about healthcare. Why are we engaged in healthcare reform? Well, I would prefer to think that the reason is that we have a moral imperative to address the 35 million plus of our fellow citizens who don't have health insurance and who, as a consequence, are prone to a shorter life, more disease, more expensive care because they get it when it's late in the course of their disease. So I think as a country, as an avowedly democratic, liberal society, we need to address this inequity that we have built into the system. Unfortunately, living in Washington, I don't hear that being such a big motivator of healthcare reform. What we hear about is the costs. Of course, the costs are unsustainable, and I think it's no question. When I graduated, as I said, in 1960, healthcare was about 6% of the GDP. Now it is 18% of the GDP. So it has been a phenomenal change over that relatively short period of time. I like to think it's short. In any event, as everybody I think understands, and which gets the most play in the press, of course, is that these costs are just out of control and have to be attacked if we're going to afford anything else in our society. In addition to that, and again, one of the issues that's not, I think, as well known, but we have, I would call it unacceptable poor quality of healthcare, generally speaking. Obviously, those of us in this room and many can afford the very best healthcare that's available anywhere in the world. But if you take the standard of care, or the mean care, and certainly the care that's available to the less fortunate, we fall far, far short of our democratic and in some cases not so democratic peers across the world in terms of measured quality of healthcare. So we have poor quality, we have overuse, we have underuse, we have misuse of healthcare resources. All of those categories of poor quality, I think, are rampant in our system presently. And then we have, not to leave this necessarily for last, there's absolutely unconscionable disparities in health and healthcare as a result, first of all, of geography, of income, of insurance status, and most regrettably, I think, when correcting for all of those other factors, we have disparities based upon race and ethnicity for reasons that are complicated but undoubtedly represent some residual legacy of our racist history, if that is still history. So those are some of the problems, some of the shortcomings of the current system. And many people like to characterize this set of problems that we have as a broken system. I think that's the wrong image to carry around in your head, because if it's broken, it suggests that, well, if we could just fix it, it would work like it used to and everything would be fine. That, I think, is an absolutely limited and inadequate model to think about. What we have is an antiquated system, a legacy system, a system that's totally outmoded. It was fine in 1960 when I graduated medical school to have a fragmented, uncoordinated system of healthcare because, again, costs weren't so high. There wasn't much we could do anyway for people. It was a time before transplants, before dialysis, before coronary artery surgery and what's the word I want? Reaming out the coronary arteries. We didn't have hip transplants. We didn't have all the chemotherapeutic agents for cancer. We had a whole raft of things that have happened since then that have made medicine much, much more complicated and more difficult to deal with. So we still have this system that we've inherited from this past, which is fragmented, and it needs to be consolidated. We need to have much more aggregated resources. Both doctors and hospitals and other healthcare providers need to be brought together in some coordinated way, not necessarily under one corporate structure, but even that will undoubtedly evolve, but certainly some way of tethering together these various healthcare resources so they can work in a coordinated way and avoid some of the duplication, some of the substandard quality, some of the cost escalation, some of the redundancy that's in the system. We have a fee-for-service system still dominating the way healthcare is financed in this country that certainly was fine when there wasn't much we could do anyway, when most of the disease was acute and self-limited. But now we're dealing with an epidemic of chronic disease, diabetes, obesity, cancer, AIDS, a whole raft of things that go on for indefinite periods of time, which require much more coordinated care. And having a click fee for every time a patient sees a doctor or sees a hospital is just the wrong incentive. It incentivizes people to do more, and that's part of and I would say probably the dominant reason why we have such an excess of overuse of medical services, because it's so easy to continue to pursue that economic endpoint. And the mode of financing has to be consolidated. We've got to get into some kind of bundled payments for these chronic disease things. We've got to get into capitated payments, some kind of way of organizing and coordinating the payment for these services so that they're not adversely incentivizing overuse. And we have, I think, a very difficult challenge of getting the unit of accountability of the system from the individual doctor or the individual hospital to systems of care. We have to hold larger systems of healthcare. Again, doctors and hospitals and other providers working in a coordinated way have to, as a system, be held accountable for the care and the quality and the outcomes of the care that they are providing, rather than holding individuals responsible, because we know that much of the problems, both in terms of cost and quality, don't come from individual actors doing the wrong thing. It comes from systems that are not adequately organized and adequately engineered to provide the kind of services that are possible to be provided when they're properly organized. And we have, again, this chronic disease epidemic that's going to require us to get into a system where it's not just the doctor working independently, even with a few helpers. We need to have teams of healthcare providers working together to deal with these chronic problems that go on endlessly. So those are the examples of kind of transformations that we need to have. We have to get from a fragmented system to a consolidated system, from a fee-for-service to a more coordinated global payment system. We've got to go from a individual accountability to more systems accountability. We've got to figure out how to have teams of healthcare workers and other providers working together to coordinate the care. So what does that mean? Well, how does that affect how the doctor is going to care for you as a human being? So that's the first question. Will your doctor still care for you as a human being under these new transformational changes that are going to occur in the system at some point? Well, it brings up the question of what is the purpose of medicine in the first place? What is the primary tenet of professionalism? It's the obligation to maintain one's interest in the patient's interest primarily. That is the touchstone of medicine, and the ethics of medicine is to attend to the patient's interest rather than one's self-interest. Well, I contend that given these major transformations that are occurring in the system, it's going to be very much more difficult for doctors to maintain that altruistic viewpoint rather than being concerned primarily with their self-interest. Well, let me suggest what that may. I think what I'm trying to say is that in this transformed system, doctors are going to be encountering new, novel threats to maintaining their fundamental commitment to professionalism. Professionalism, after all, is a set of behaviors that required of the individual physicians in order to maintain the trust of the public and maintain medicine's part of the social contract. The social contract, which has been an unwritten and often unspoken relationship between the medical profession as a profession vis-a-vis the public that supports it, in return for all of the special advantages that physicians and medicine in general has in terms of being able to identify their own people who are coming into the profession. All the admissions requirements in medical school are set by the profession, they're not set by the government. We determine the research agenda in the profession. It's not largely set by outside influences. These are the consequences of the professional judgments that are made. We obviously enjoy a certain level of status in the community that's a consequence of the willingness and the commitment that the profession has to serve the public. So the primary trade-off is the privileges that the profession receives in return for the obligation to treat the public and individual patients as the primary interest. Well, that fundamental social contract, I think, is in danger of having some very significant threats placed on it in this setting. So I think what the public is now expecting from doctors is much different, or will certainly be much different than what has been the standard in the past. First of all, the issue of autonomy. When I went into medicine, again, back in the dark ages, I was telling Millie before, the primary thing that was in our heads that we wanted to be our own boss. Is that how you felt about it? This was the prime. I mean, it was great. It was good science. It was opportunity to give back, to care for people. We know we make a reasonable living. But the thing that really drove most people into medicine at the time was they really wanted to be able to determine where they worked, how much they worked. Nobody looking over their shoulder. They were responsible for their own activities in the profession, and it was a very compelling reason. And I think one of the reasons that our generation of physicians, by and large, or at least in many cases, are disillusioned, is that those expectations haven't been realized, and there's now much less autonomy, I think appropriately so. But anyway, I think that is a reason why many of the current practicing physicians find themselves disquieted by the current circumstance, because they're not any longer as much in control of their own destiny as they thought they would be. So what we're moving towards is a move from autonomy to accountability. I think we have to recognize that doctors, hospitals, anybody in the medical profession, if they're going to be serving the public, have to be accountable. They have to be transparent in what they do. They've got to demonstrate that what they do is in fact in the patient's interest or in the public's interest. So this movement from autonomy to accountability is not a trivial exercise for people who have been drawn into the profession for other reasons. We also have a transformation from the doctor knows best to a situation of shared decision-making, where patients and patients' families are now expecting, and I think appropriately so, to be part of the decision-making. That's not just the doctor dictating what you want to do, unless that's what you choose, but most people now are preferring to have some say in the choices that are being made on their own behalf. We clearly are also moving from the question of individual needs to a societal needs. That is, the focus has always been and will continue to be on the doctor-patient relationship and what's good for that individual patient. But increasingly, we have to recognize that dyad takes place in a much larger context, in the community context, in the family context, in a countrywide context, where the consequences of the decisions that are being made in that doctor-patient relationship have financial implications, have public health implications, have several issues that go beyond just the single doctor-patient relationship, and that again is a new challenge for doctors to have to contend with. Doctors have been the captain of the team, insofar as there's been a team in the past. That's being transferred into a situation where we're working as members of a team of other health professionals without the hierarchical arrangements that's been so common in medicine. Again, I don't want to talking about it quickly, but it's a substantial challenge to the culture of medicine to think about physicians having co-equal status with nurses, physician's assistants, physical therapists, others in the system that have important and unique contributions to make to the overall management of these complex problems. So that the doctor being to recognize that there's a limit to what the doctor can do, and there's a need to engage on an equal basis the professional capabilities of these other healthcare providers. We have a very rapid change now from self-employed physicians to employed physicians, where again this notion of autonomy is now being receded to. I think more than half of the doctors in practice now are working for some corporate entity or some large system of healthcare, not necessarily a for-profit one, although that's increasingly the case. But many of the nonprofit hospitals now are acquiring physician practices, and doctors are now working for hospitals, and at least half of the doctors in the country now are already in that kind of a situation. And the younger physicians who are coming along are very much more interested, by and large, in that kind of an organizational arrangement for their professional activities. It gives them a chance to have a better lifestyle, more control over their time, more colleagueship, and so forth. But in any event, that's a major change in what the way doctors are going to be employed and compensated for what they do. And finally, there's this change in the fee-for-service system. As I mentioned, this is going to be, I think, a crucial transformation in the way we finance healthcare to get out of the click fee, fee for every single piece of service that's provided by a hospital or a doctor, to a pay-for-performance mode in which quality of the outcomes of the encounter with the physician are going to be increasingly looked at, evaluated, measured, and used as part of the compensation for the physician. That is entirely new in the profession, and one that I think is going to take a lot of readjustment in terms of doctors' attitudes about what they do and why they do it and how they do it. So these changes in terms of where doctors are practicing, how they're being paid, what kind of system is going to be accountable for the activities that go on in these settings is going to create a tremendous amount of stress and again, threatening to the maintaining of this professional ethic, in my view. Let me give you some examples of the kind of things that I think are going to be problematic or could be problematic in this transformed system. Well, in terms of upholding the primacy of patients' interests, how are we going to avoid underuse of services when we are being paid a salary and being motivated to be more productive and to do things that are going to be affecting the bottom line of the system with which we are in which we're working? Heretofore, the major threat to this kind of issue was overuse of medical services, where the fee-for-service reimbursement mechanism, as I mentioned, has, if anything, incentivized physicians to do more and hospitals to do more when they've been paid in that way in the past. But doctors certainly, if they're in a fee-for-service situation, or have no incentive to be parsimonious in the way they approach their responsibilities, because the financial incentives are in the other direction. In this new system, it's going to be just the 180 degrees reversed. There's going to be a challenge to avoid underuse of necessary services for patients, because that's going to be the economic incentive in these large systems. There's also going to be a question of maintaining confidentiality as we get into electronic health records and with the sharing of information across these large systems. It's going to be a real challenge to maintain privacy and confidentiality in these settings when that is such an easy thing to avoid. Managing conflicts of interest, critical issue. It's been critical in medicine from time out of mind, but I think the kind of conflicts of interest that are going to be important to recognize and manage, again, are conflicts with the system's bottom line, the system's values, and the individual patient's values that the doctor is responsible for. If those come in conflict, I think physicians are going to have a challenge to balance their responsibility to the corporate entity or the system within which they're working, if it's at variance with what they think is right for their own patient. So that's another source of potential threat to maintaining their professional ethical stance. I mentioned the transformation of the hierarchical medical culture as another major issue in terms of professionalism. The interpersonal relationships among various healthcare providers, I think, is going to be an issue that could culminate in some untoward relationship issues between nursing and medicine, between physician's assistants in medicine, between nurse practitioners who are increasingly having the capability to do many things that doctors have been uniquely allowed to do in our society. It's going to lead to another set of potential conflicts. And improving the quality of healthcare, again, another mandate that I think all of us recognize is necessary if we're going to get rid of this variance in quality outcomes. We have to embrace accountability in a way that hasn't been the case in the past. As I mentioned before, doctors have traditionally been able to do things on their own recognizance, that's not the right word, their own volition. They've decided what to do without anybody looking over their shoulder. Increasingly, everything that the doctor does is going to be measured, it's going to be evaluated, it's going to be compared to other physicians in similar circumstances, and it's going to be transparent, so people are going to know how doctors compare one to another in terms of their performance, and this is going to be incorporated into the reimbursement system as an entirely new set of conditions that doctors are going to be working with, and that's going to, I think, potentially lead again to some threats to their professionalism. And then enhancing patient satisfaction, doing things that are important for patients. From the patient's point of view, the patient-centered care movement is, I think, long overdue, but again, places doctors in a different relationship many times with their patients than has been the case in the past. So the question is, given all those threats to professionalism, will your doctor still care for you as a human being? Well, I say it depends. And I think what it depends on is whether or not the doctor is deeply committed to the ethics of the profession. If they understand that medicine is a calling, and that inbred or inborn, innate nature of the physician's motivation comes from that sense of obligation to the patient to do what's right for the patient's standpoint and not for self-interest. What I like to, what has been called this passion for the profession has been called humanism, and I think the humanistic physician is the one who is, again, hard to measure what humanism is, but it's a commitment to others, especially others in need, and it manifests as duty, integrity, altruism, compassion, empathy, caring. Again, the touchstone of medicine, all of us who went through medical education, I think even now, are familiar with the phrase that was coined by Francis Wells Peabody in the early 20th century. He said that the secret to the care of the patient is caring for the patient. The secret to the care of the patient is caring for the patient, and that's really captures, I think, the fundamental issue here that's at play. And as long as we have physicians who are passionate about that aspect of their responsibility, that they want to care for patients as human beings, that's the kind of doctor that's going to be most able to withstand these new pressures that are coming down that are going to tend to deviate his or her performance from that fundamental ethic. So that's the answer to the question. I think, yes, your doctors will still care for you as a human being as long as they remain firmly grounded to these age-old humanistic ideals in medicine. So, Millie, I've taken now half an hour, and I think I'll stop right there because I think that will be enough food for thought. So thank you all for your attention.
That was a wonderful, wonderful presentation. And what we thought we would do is we would just allow me the privilege of the moderator to start off with a few questions and then open this up to be a conversation. I'm so sorry about this noise.
We have been trying
noise.
very hard to get that resolved. I'm very sorry.
Yeah. Anyway, where to start? I have a couple of questions. One is you started off by talking about the moral needs for changing the system. So you, in a way, pointed out the moral problems with the fragmented system, 35 million people uninsured, and legitimated that we really need to do something differently. And then pointed out that the perils that we had in our current system, overuse especially, now we're going to get flipped 180 degrees to underuse. So is your sense that the kinds of reforms we're seeing are necessary and we just have to manage them? Or is there an implicit concern that the remedies we've been designing are not as nuanced as they should be?
Well, that's a very good question, Millie. And I think we won't know the answer to that until we actually have some redesigned systems and we can actually see what the consequences are. But I think just reasoning from first principles, I think there's little doubt in my mind that we have to get out of, for example, the fee-for-service system. I think fee-for-service is simply produces such adverse incentives in the system that it's hard to understand how we can actually manage the overuse of services as long as we have this financial system that's driving physicians and others to use more and more services. So that's one issue. In terms of the quality issue, it seems to me it's going to be impossible for us to really, first of all, get the data to understand where the quality opportunities are that we need to work on, let alone how we're going to actually implement remedies to those quality issues, unless we have a large enough system where the data are going to be aggregated in a way that can make statistical sense, and where there is management of the system that can actually influence the way in which care is delivered. I think one of the problems is that we're depending upon individuals isolated from one another or from each other to make these quality improvements, when much of the quality problems are not at the level of the individual practitioner, but they're at the level of the system. We have such a complicated set of interactions in this modern age of medicine that unless you have a system that is attentive to these complexities and can manage the complexities in the way that, first of all, again, can identify where opportunities for improvement are and can then implement remedies to make those improvements happen. So I don't see any way that we can deal with the present system. It's not broken. It is inherently incapable of meeting the tests that the current set of challenges in the society are presenting to it. That's why I think this notion of a broken system is not an adequate way of thinking about it. We really have to think about the system, the non-system we have now is not broken. It's simply, it never was designed to do the job that needs to be done. It's the analogy I like to use is, take a Model T Ford. You want to make it fly? Put wings on it. Put a bigger engine in it. Put aviator glasses on, and see if you can make the thing fly. I mean, that's what we're trying to do. You know, we cannot retrofit this system to make it meet the current needs that we have for us.
It's so extraordinary because Dr. Cohen is a leader from inside that system who has been talking about its problems. So that leads me to my next question, which is, polls show that Americans trust their individual doctor more than just about anybody else. And when you look at the civil or uncivil discourse about healthcare reform in the United States, there seems to be an implicit belief among our citizens that they get great healthcare. They trust their doctors, and America has the best healthcare system in the world. That seems to be kind of the spoken and unspoken cultural narrative.
Right.
So it's extraordinary, first of all, that somebody who's a leader from inside the system can talk about its problems. But my question is, how can we help, and all the physicians and healthcare providers that I'm familiar with know in their heart that we have to fix something and that there's a problem here, but I don't think the public does. I think they're saying, you know, why are we changing anything? So how do we move the public discourse?
That's a very good question. I'm not sure I can answer that, but I'm going to comment on your observation. I think it's true. I think patients do generally trust their physicians. And I think it's not too hard to understand why, because they have to. Okay? I mean, what choice is this? If you don't trust your doctor, you know. So I mean, seriously, so I think that's part of the dynamic. Most people who are commenting on the nature of the healthcare system are not in it at that moment. When they're sick, they can appreciate the deficiencies that exist, but if you ask someone who's not ill, who doesn't have a need for medical services at the moment, the system looks pretty good. You know, they can see their doctor when they need to. They can go to the pharmacy and get their medicines. They got insurance, if they have insurance, that will defray most of the costs that they have. So it seems to be working for them at that level. And then add to that, I want to be careful how I phrase this, the out-and-out lies that are being told about the nature of the reforms that are currently being proposed have led people to be very suspicious about the reforms, to think that what they have is better than what's being provided. I think there's been such misinformation, either consciously or unconsciously, about the nature of the reforms that are current. And not that they're, let me back up and be sure I'm not misstating my belief. I very firmly believe that Obamacare is a very important first step to get us to where we need to be. It's going to take a generation of changes in order to fix this system and get it redesigned appropriately. it is so far from perfect that it lends itself to a lot of criticism, a lot of appropriate questions about whether or not other things might have been done. Given our political system, given the realities of the opposition that has been mounted against Obamacare, given the fact that certainly no later than Harry Truman, there's been attempt after attempt after attempt to get some kind of healthcare reform established and started. I think Obama has to be given credit for at least giving something on the road to improvement. It is, again, far from perfect. It needs a hell of a lot of modification, a lot of additional work, particularly on the cost control issues, which are hardly addressed directly by the law. But anyway, there's a lot of reasons to be unhappy about what's happening. But in comparison to what we have, it is at least a template for getting us moving in the right direction that can be modified with time. But given the fact that it's been so bad-mouthed, to put it mildly, in the press and elsewhere in society, that people get the notion that it's not a good idea. And I think that's part of the reason that we are where we are.
All right, I'm going to just ask one last question. I know I'm extending my privilege a little too far, but I really would like to ask you. You talked about the potential split loyalties or dual agency a physician may feel between caring for the patient in front of them, the individual, and the corporate entity to which they work. That stirred me to think about the potential conflict that an earnest physician would also feel between the individual in front of them and the community that they're meant to serve. And these aren't necessarily corporate issues at all, but a desire to deploy our resources in the most effective manner and make decisions about allocation of resources that will benefit the community as a whole, that might actually mean that the patient in front of them doesn't get the most expensive chemotherapeutic agent that only adds a week or two of life. How do you see the professionalism implications of physicians? Do physicians have a responsibility to the community, or only to the patient in front of them?
Well, I think for sure they have a responsibility.
And how do they navigate that?
Well, I think it's another very good question, Lee. I think and when it comes to the final analysis, I think there's probably an irresolvable conflict between some of those. What's the ethical word I'm looking for? Some of the shared goals that they're trying to achieve. They're fundamentally in conflict. To take it at the macro level, the difference between public health and medicine, that's a glaring example of the kind of disproportionate emphasis that we place as a society on the curing aspects rather than the preventative and behavioral aspects that are very much more, or at least certainly very important in terms of determining illness and maintaining people's good health. And I think, I heard, or implicit in your question, if it's carried to the extreme, the unavoidable R word.
Yeah, well, I was hoping you might go there.
Right. And I think at some point in our society, I don't know whether any of us will be alive when it's ever on the table, but rationing has got to be addressed. I mean, it's not as if we're not rationing now. I think everybody knows we're rationing healthcare right and left on the basis of geography, income, race, you name it. So there's all kinds of rationing, that is to say, people not getting care that they could otherwise benefit from because of the way the system is operating. If we were going to do a rational set of rationing guidelines, which, again, it's so hard to predict. I think, given the fact that we have, let's take the common economic consensus that some 20% of the current expenditure on healthcare produces no benefit, wasted, if you will. Let's say we could squeeze all of that out, get 20% of the current expenditure and actually apply it to useful services that people would benefit from. It may be that with advancing technology that we will reach a point where we can actually reduce the cost of healthcare by various technical and other means, but given the current trajectory of technology, one would have to at least entertain the real possibility that costs are going to continue to rise. It's just, even if we can get all this 20% waste out and do only those things that are that are useful and do it in an efficient, productive way, I think we're going to end up at a point where we're still going to have too few resources unless we're going to put even more resources into healthcare than 18% of the GDP. But if we're going to be somehow constrained by how much money we're willing to spend on healthcare, I don't think we're going to be able to afford everything for everybody that could, on the margin, be measurably helpful. It's just going to be too expensive to do that. So what does that mean? That means there's got to be some way to limit what one does for people, even though it would otherwise be helpful to them. End-of-life care is certainly a place where one could address a lot of those issues. As everybody knows, I'm sure in this room, we expend a way disproportionate amount of money at the end of life for patients. In many cases, at least in retrospect, one wonders whether or not that was a useful investment of resources. But I think we're going to have to figure out how to do this in a more rational, more contemplative way than we're doing now.
So now it's your turn. And we have a microphone. So.
Thank you so much, Dr. Cohen. I have worked in critical care medicine in two socialized healthcare systems, one in the National Health Service in Britain and one in the National Health Service in Saudi Arabia. I'm fascinated by what you said about the spectrum of underuse. In both places, what I found, to my astonishment, I missed most was the spectrum of medical malpractice, which was not very aggressive in both continents when I worked there, and the absence of competition. When you return to American medicine, at least here in New York, there's a great deal of competition for the patient, for the procedure, getting the patient out of the hospital, and I felt that compromised some aspects of care in other systems where those behaviors were not, they were not part of the culture. And additionally, in England, I stopped practicing critical care medicine because the physician was duty-bound to society to not ventilate an aged patient, and I found it became too much of a gatekeeper role. So I want to hear your thoughts on your fears about underuse here in the United States and what you've learned about other socialized medicine elsewhere.
Well, I'm not nearly as familiar as you are with the way these systems operate in other circumstances where the incentives for overuse are not as evident as they are here. I think it's hard to predict. I worry that given the way in which human nature operates and the way in which people are responsive to the kind of incentives that they're confronted with, that if they're working in a system where the system is looking at what they're doing in a way that's been not historically a part of the pattern, where they're measured by everything that they do, where their productivity is going to determine in some degree how well compensated they are, whether the system is going to require more attention to their bottom line than is currently the case, whether that's going to place such a burden on the individual physician that there will be conscious or unconscious tendency to, well, that certainly is the right thing to do for this patient. Maybe we could cut a corner here. That's the one thing I worry about. And I don't know, again, my own bias, as I think I tried to indicate, is that unless the physician is strongly motivated to do the right thing by their patient, it's going to be difficult for them to withstand the corporate pressure to deviate from that. So that's why I think it's so important. I didn't really emphasize this in my talk, but I think medical education has a huge obligation here to, first of all, identify physicians or students to come in. I think everybody recognizes that it's the admissions committee in medical schools that determines who practices medicine in this country. Very few people admitted to medical school fail to get an MD degree, and if they want to practice, fail to get a license. So it's really that first entrance into medical education that's the gatekeeper, if you will, for the people that are actually going to populate the profession. So the more we can emphasize the kind of quality of character and inclination and motivation that these future physicians are going to have, the better we're going to be in terms of the end result. In addition to which, all of the education and training that goes on for the 8, 10, 12 years has to be organized in such a way that strengthens the resolve of physicians to to continue to adhere to those fundamental principles. I see that. I don't see any others. I don't see any patient's bill of rights or any regulatory system, any external things that are going to suffice when it comes down to a closed door. You're sitting there with a patient. You're making a decision about what to do. If you don't have inside of you that strong commitment to do what's right, irrespective of all the conditions that may be playing on you, I think it's going to be a very difficult thing to maintain what we like to think is the ideal trust in the system.
I worked for many years, thank you for being here. I worked for many years, 10, for the Medicare Rights Center. I went back to school, I had a PhD in sociology, and I wanted to make a difference with healthcare for patients. My question is, do you see any way that informing patients about some of the things that you have mentioned could lead to any impact on how the healthcare resources are allocated, specifically to address what you mentioned, that so much of the care for older people relates to chronic conditions. And we do not, Medicare does not pay for most of those, the needs that patients need. So I'm involved in an organization now that's educating people about this. The problem is that when people find out that there's no money to pay, they are so involved in the issues that they don't have the strength to take political action. So that's one of my major concerns. How do you get an educated consumer lobby? And would this be a waste of my time?
Well, I think the core of your question is how do we really engage the public in better understanding what they want and what they need. I mean, heretofore, it's been, again, this is an oversimplification, but it's been the profession and the politicians that have spoken for the public in determining, often for not terribly transparent reasons, what is going to be provided. Whereas I think the more we can engage the public in a dialogue and an intelligent conversation about these issues, the better informed public policy is going to be. Let me just give you a personal example of this in a couple of the organizations that I've been involved with. I started out in working in some of the national organizations that had no public representatives on their governing boards. In the past decade or so, there's been a movement to try to encourage and, in fact, incorporate knowledgeable public members in some of these organizations that are making decisions about how to accredit medical schools, how to accredit residency programs, how to design care systems. And this has been an extraordinarily positive development, at least in my personal experience is anecdotal, I admit, but I think it's generally conceded that when the public is invited in to these inner sanctums that have heretofore been such closely held bodies, it's been a breath of fresh air. It's been new perspectives. It's been an authentic sort of input into the kinds of policies and processes that are incorporated. So I think the more we can engage the public at all levels in these very complicated set of issues, I think the better we're going to be in terms of understanding what the public needs and having the public better understand what the challenges are inside the profession to try to accommodate the sort of things that are desired. So that I think medicine is in the business of public service. And being in the business of public service, you got to engage the public in finding out what it is that is really important.
You brought up Medicare. You committed your life to, a good part of your 10 years, you said, to Medicare rights. Wouldn't it be wonderful to imagine a public conversation where we could suggest redesigning Medicare, which now is completely incentivizing payment for highly skilled technical medicine and not at all reimbursing any of the high-touch things that people with chronic illness really need, like unskilled help in their homes, transportation, all the things that, all the long-term care needs that we have no way to fund. Now, if we could get that out on the table, But right now, if you talked about redesigning Medicare, you can hear how people would say that's rationing, or that's death panels, without a real mature conversation about the fact that, well, what do you think is most important? How can we start to redesign Medicare so it extends to the whole continuum of what's needed, not just to the one end? But we can't have, we just seem frozen, unable to have that kind of conversation now. David.
Doctor, your comments tonight have been nothing short of heretical, and I thank you for that. It's remarkable to me, as someone who's been in healthcare for his entire career, to hear somebody from the medical and medical educational community speaking the way you have been. It's really refreshing.
Well, my voice is not unique. I think there are a lot of people who feel the way I do, so don't put too much of a burden on people.
Good. So let me now press you, as one of my ethics professors used to say. Do you have a sense of the unique moral role for physicians in the healthcare delivery system as among all of the allied health professionals? And are we going to have enough physicians to fulfill that unique role as the baby boom population ages and the demands upon the healthcare system grow?
Well, that was the second part of my talk. I didn't have time to deliver, so let me deliver it now. No, we're not going to have enough doctors to deliver the care in the traditional way because, first of all, the population is growing, population is aging, we've got a lot more chronic disease that we have to manage, so I think there's no question about the fact we've got to find ways to disseminate's not the right word, but to incorporate other healthcare professionals in this team approach to managing chronic illness in particular. I think we're going to be very greatly benefited by the technology that's developing in terms of being able to monitor people's conditions at home. I mean, there are phenomenal new techniques that can do blood pressure, blood glucose, weight, all kinds of simple and sometimes not so simple measurements that people can continually monitor wherever they are and have that information fed back to the system that's responsible for their care. So I think there's these kinds of very sophisticated and I think quite disruptive technologies are going to be very, very useful in terms of making it possible for the limited number of physicians, even with the expanded workforce in terms of nurse practitioners and physician's assistants and all the rest. I think it's going to improve the productivity of those teams because they're going to have a great deal more access to the information that's going to be timely and useful. But the core of your question was, does the same ethical dimension, or moral dimension, permeate those other professions? And the answer is absolutely, particularly if they're part of teams that are imbued with this sense of responsibility and accountability. I happen to believe, and it's I'm sure a biased point of view, that doctors will be in a very strong position to influence the way in which that kind of ethic and that kind of ethos permeates these teams. Because I think they're going to be more highly educated. They're going to hopefully be more deeply rooted in these traditional virtues, and I think so they'll be in a position to ensure that they are in fact manifest in these larger organizations. So, but I certainly don't think that doctors are uniquely in a position when others are not. That clearly is not, I think, the way it should be or it isn't.
At my hospital now, and I think most in the country, a very high percentage of the institution's effort is now devoted to the federal government's mandates for data collection, electronic data collection. Right now we're involved in something called ICD-10, which for the people, it's basically the number of billing codes that's been expanded by about 100-fold or more. So you have to go very specifically, a lot more information about diagnosis, and something called Meaningful Use Stage 2, which again is the federal government's requiring that someone enter data into a computer and send to the federal government about what the doctors and nurses are doing. So the only people who can do that are actually the doctors and nurses. And so first, it's a very high percentage of the institution's budget. And second, people are concerned that focus on entering data is taking the physician and nurse's attention away from the patient And I'm just wondering what your thoughts about that. It just seems like organized medicine hasn't made too much of a fuss about it. A lot of money involved. No one knows for sure it's really going to do any good. What are you thinking?
Well, there was an article in the Times just a few days ago about scribes being hired to...
Right, if you're a dermatologist, or if you're in a very high fee field,
Right.
you can afford that, but the average primary care doc, not going to be able to hire a scribe.
Right. Well, I'm thinking about the system, though, in which you're working. In the ambulatory setting, I can see that could be a major problem. I don't have an answer to it. I think, we're still in the early stages of this electronic health record and all the things that are required of it. It's conceivable to me that things like voice recognition, so rather than having to write everything out, you can be able to speak it as you're doing it, and that will save a good deal of time. And I'm taking this off the top of my head. I don't know if that's going to be a meaningful change or not, but I think that's the kind of thing that, recognizing that we are in the very early stages of the adoption of this technology, and technology is, as you know, advancing at such a great pace, that I have some confidence that given the fact that that's a problem that's being identified, that there'll be ways that some nerdy guy at Harvard is going to invent a Facebook solution to this kind of a problem. Maybe.
If I could just jump in here for a second. I think it's important to share with the whole group. I mean, one of the reasons behind meaningful use standards, so because they relate to what Dr. Cohen was saying earlier about making sure that we don't trip into the underuse problem. Because the only solution, now that we're changing the incentives for healthcare, and we may move from overuse to underuse, which is an equally or worse problem, is to have quality data. And so at least the thought experiment that is now being enacted is beyond thought. What's being implemented now is the reason behind this data collection is to make sure that we can have quality data and that we can tell whether or not there is under or overuse. And that's really the main drive for this kind of thing. So I guess it raises privacy issues and confidentiality issues. We have to sort those out. And yes, it's really burdensome right now as we're beginning to design the system. But the thought behind it, the meaning behind it, is to have a remedy, or at least some way to mitigate this concern about under and overuse, to study what we actually are doing and have some kind of quality control. Because if costs went down through all these changes that are happening, but we didn't have that data, the costs could be going down for bad reasons. The costs could be going down for underuse. So the only way to know is to collect that kind of data. So I think we're kind of caught in a situation where it's not pleasant to do, and it is expensive for institutions to set up. But that's the reason behind it. So we have to figure out how to manage that, I think.
Thank you, Dr. Cohen. Underuse, overuse, the data collection to determine where productivity is, where we rationalize, or ration, I should say, more, where we can squeeze a bit more out. These all sound like very difficult things and worthy, but it's also very complex. What do you see as the role of prevention, particularly in light of what I've heard many times said, is that a lot of the costs we have are for chronic conditions that maybe through lifestyle choices and other activities could make a really big, maybe even a bigger difference. And wouldn't it be nice if your doctor could be the person to lead the team that's more, gives you a holistic plan how to prevent?
Well, again, my optimism, and to answer your question, it comes from the expectation that if we can get consolidated systems of care, large aggregates of being responsible for a defined population of patients, I'm talking about thousands of patients being in this system that's going to be collecting the data and being cognizant of the opportunities for improvement, coupled with a budget that system has to deliver the care that they're delivering to that defined population, and it's measured. The quality of the care is being measured because the data are going to be there. That is going to set up an absolutely unstoppable tendency to identify ways to prevent illness from happening. And there's a huge amount that can be done in terms of life. I mean, it's not easy. I don't mean to imply that getting people to stop smoking, getting people to adhere to their blood pressure medication, getting people to do all the things that we know are helpful in terms of minimizing the progression of these chronic diseases, or even the occurrence of them in the first place, that there's going to be a tremendous incentive to do that, because the only way this system is going to make a go of it is if they can reduce the burden of illness that they're dealing with, given the fact that they're going to have a defined budget to work with. So I think that the system is allowed to develop in this way, that we're going to have built-in mechanisms that are going to address that issue in ways that we have found impossible to do now. I mean, you depend upon the individual doctor. You should stop smoking. That's it. Just stop smoking. Yeah. So that's not going to do it. So you got to have. There's got to be other ways in which one approaches these behavioral and non-biologic determinants of so much of the burden of illness that people experience in this country.
Okay, I think we have time for one last question.
Thank you for a wonderful talk. It's interesting to me, you opened your talk by saying that you come to us today from Washington, D.C., and that the echoes that you hear there, a lot of the legislation are perhaps not being, and changes in healthcare and reform are not being made perhaps with the most altruistic motivations. You also mentioned multiple times in your talk the word corporate and larger systems. That was a term that we heard tonight multiple times. You also mentioned how physicians over time, certainly since in your experience, since you began as a physician, the autonomy has certainly changed, and the playing field is now very different. Is it your experience or your sense that given these things that physicians are active enough in voicing their opinions, or involved enough, or being allowed to be involved enough in decisions about healthcare reform in this country and changes that directly affect them and their practices?
Just so we can get to the food, no. No, the point you're making is that in the absence of having really strong physician input, properly motivated physician input into these decisions, I think we're going to be at the behest of people who are not as well versed in what the actual issues are that have to be addressed. And I think we're seeing that. I think, I don't want to be overly critical of the AMA, but I think for a long time they've not been as forceful a voice for reform and doing the things that are, I think, in keeping with the public's interest that I would have preferred the major voice in the profession to have. I think ever since they decided that Medicare was not a good thing to do in 1965, that was not a good decision on their part. But I think recently they've become to be, I think, more effective in voicing some of the principal changes that are needed. At least they've endorsed Obamacare as an example. But that's on the surface of it. I think the burden of your question is: are there really strong, well-meaning, grounded physician voices, medical voices in the policy arena that are helping to shape these policies? The answer is absolutely not. We are. I think how many doctors are there in Congress now? Something, a handful, maybe 5 or 10. How many lawyers are there in the Congress? So I think you're right. I think if we could find ways to get a broader involvement of the profession in some of these decisions, it would be, I think, very helpful.
Jordy, if we could find more physicians to play the kind of role that you've played, please join me in thanking